Hello, Ian. Thanks for recording the meeting.
You got it. How are you?
I'm doing good. Oops.
You survived your trip. Now you're back.
Barely, yeah. Re-entry after being off is
Yeah,
coming.
exactly. Have to go to rehab post vacation.
Right, right. You need the little time to set aside to catch up. Hi, Jen. Hi, Arlen. Thanks for joining us. Hello, Stephen.
Hello. Happy June.
Yeah.
Good evening.
Hello.
Hello, Stephen. You
Hi.
guys not know Steve logs in every month from New York. We're really glad to have him.
I changed my background
Oh, you did?
from snow to springtime.
That's what we all need.
Well, say hello to my son in the Big Apple.
Well, the weather is slowly changing, still pleasant. Only one day when it hit the 90s.
Was that last week?
I think it was last week. Yeah, now it's been in the 60s. Not bad.
Okay. Yeah, still officially still spring, not quite summer yet, so. Hello, welcome to the meeting. Hello, Tim. Glad to have you. Oh, I can pop up the, ooh. Oh, really nice, Steve. That's beautiful. That can't be in New York.
Upstate?
Maybe? Have us guess. I'll go ahead and share today's agenda as people are logging on.
Did you just want to see what was in it?
No, I just wanted some. I ate some at 3 o'clock in the morning, and I took
Did
better.
you cook it?
No,
Oh, I thought you did have to cook it.
I can hear you. Are you looking at the agenda?
Yeah.
Oh, okay. All right. Can't tell what I'm sharing. Welcome, everyone. Thanks for jumping on to our community meeting today.
JFK is now one of the Ebola screening areas
Oh,
in the
really?
United States.
Oh, they're screening at the airport or something?
I guess I'm getting alerts from the health department and other agencies.
Ah,
As if our nursing home is going to get Ebola cases.
Oh, wow.
guess it helps to be prepared.
Well, this is not the first time we've gone through this stuff.
Yeah. Interesting. Well, it's a minute after. Say hello and welcome to everyone who is on our community meeting today, and hello to everyone who's jumping on. We have a wonderful agenda today that you can see on your screen. And what we'll do is we'll start with a brief announcement and request from the CDPHE Emerging Infections Program. And then we'll talk about the dyslipidemia guidelines from Dr. Horne. We have Chad Fear and Jenny Albertson today here to give us updates from CDPHE and the CHCA. And then we will conclude and invite you back to Journal Club this coming Thursday. So do we have our team of, with Dr. Czaja, the Emerging Infections Program Surveillance Projects? I know there's a bit of a team of people who will be sharing today.
Hi, this is Chris Czaja. Can you see me or hear me?
Yes. I can see you and hear you.
Sorry, it took me a second to get this set up on my phone so I could call in, but
Sure.
I am very excited to call in here from Boston. I'm the Healthcare Associate Infections Program Manager in Colorado, and I'm currently in Boston at a conference, but wanted to talk to you for a few minutes about a project that we're working on and hoping to recruit a couple of nursing homes to participate in. So my name is Chris Czaja. I am an infectious disease and public health physician and medical epidemiologist at the Colorado Department of Public Health and Environment. And I can't see who else is on the call, but I think probably the staff that we're going to join include Helen, Johnston, Alana Silwick, and Catherine Emanuel from CDPHE. And we also work closely with Dr. Ellie Abraham from the Colorado School of Public Health. I'm on here sort of representing two aspects of this. We are the Healthcare Associated Infections and Antimicrobial Resistance Program. And our mission in Colorado as a disease control program is to prevent the spread of antibiotic resistance and prevent healthcare infections where we can. But we're also the site of the Colorado Emerging Infections Program. So we're one of 12 states in the United States that was funded to collect information related to communicable diseases in healthcare settings. And we do that to, one, share that information with Colorado stakeholders, but also to inform the national picture. And CDC uses the data from those 12 states to build a picture of what the burden of infections and the needs are in the country. That is to inform policymakers and hopefully translate into resources and funding in some cases. So an example of the work we've done in the past include nursing homes has included a nursing home survey of healthcare-associated infections and antibiotic use. And so the idea there is we can get an idea of what percent of nursing home residents may have a healthcare infection, how are antibiotics being used, give the people who are making the decisions and the policies around this some information to make informed decisions, but also to give that information back to Colorado nursing homes to help you all with the quality of your care, which we're all, I think, all interested in. So the problem with some of that work is that it's relatively slow to develop. Public health surveillance takes, a couple of years to collect data, clean the data, review it, and get it out there. And so it's very helpful for understanding things on a longer scale. But CDC and EIP have this idea that, especially following the SARS-CoV-2 pandemic, that nursing homes need information more quickly, and that we'd like to build a network where we can collect some of this information with you in a more rapid time scale that might be more actionable. So we are one of 5 sites in the US, including Connecticut, Georgia, Minnesota, and New York, that have the opportunity to develop what's called a nursing home network for this purpose. The idea is to respond to the communicable disease needs in nursing homes in a timely manner by pulling together groups of interested nursing homes that want to be sort of at the table of the champions for this work. And it's motivated, as I said, in part from the experiences with early SARS-CoV-2. So in Colorado, we're looking for 5 to 8 nursing homes. I think we have 2 or 3 that have expressed interest and we're working with. To give you an idea of what the projects may look like, the first is just to convene people to the table. But to get things started, we're looking at unplanned hospitalizations and trying to understand the reasons for that. Some of the other ideas that have been tossed around for the future include looking at post and pre-sepsis care, as well as antibiotic use in nursing homes. So before I get into the why would you ever want to be part of this, just to give you some idea of what the requirements or the requests are, is that we really want to work with people who are interested in quality and can champion quality and work with public health. You do have to be willing to work with us. We're not the survey and certification group at CDPHE. We do work with those folks on occasion, but this is not This is not that. This is quality work in public health surveillance. There would be minimal data collection on the part of the nursing homes. The CDPHE staff on this call would be collecting those data, but we would want to have access to electronic health records. And that's something we could work with you on. It's something that CDPHE has both the authority and the experience and the regulation around how to use those records that we do it for public health on a regular basis in other settings, and are bounded by law to keep information safe and confidential. So why would you might consider doing this? I think the first thing, if it were me, would be to be part of the conversation, to join the conversation around the public health needs and communicable disease needs and healthcare infection needs in the nursing home, and share those needs and share those challenges, both with other nursing homes that are part of this network, but also with the public health folks who are working to support that work. The second would be we would review the data collected from these nursing homes and feed them back to the participating agencies. So you would have that information available and summarized, and you can use that for quality work or however you'd like to use it. The third would be able to inform the national picture, to be at the table in terms of representing the findings and the needs of nursing home residents. And the last, which I think is kind of the vision, and we'll see how this actually pans out, but to prepare for the next response. So by engaging with public health and working with us and sharing some of the setup around conducting special projects, looking at some of these data, it's meant to be a skill building exercise that allows us to respond more flexibly in the future. So I want to ask if Catherine and Manuel can put her contact information in the chat. But if anybody's remotely interested and just wants to talk more about this, you can always reach out to me or any of us on the call. Catherine is the lead epidemiologist who is leading this work. And I will stop and we can answer questions. And I'm sorry that I'm on it's like a phone app, so I can't see the chats. And so if somebody can moderate if there are questions, that'd be great. Thank you very much.
Dr. Rogers, do you want to ask your question? I can ask for you. Dr. Rogers put in the chat
I
box.
got it.
Okay, go ahead, please.
Maybe they're already going to touch on this, but we need to know, who the personnel involved, how much time, is PCC good enough, stuff like that.
Yep, and I see Catherine's put stuff in the chat, so maybe she would answer that now.
Yeah, I'd be happy to answer both of those questions. So personnel needed, we're looking for a point of contact in each nursing home to be ideally the director, assistant director of nursing, maybe the infection preventionist. We just need one go-to person who would be able to answer questions for us, help us get set up with external access. Regarding time, I think probably 5 to 6 hours of time completing. There's one brief survey that has some questions about practices within the facility. What kind of electronic health records are you using? What kind of care are you providing? What does your census look like? Things like that. And then helping us get set up with access to point-click care, which would be sufficient. That seems to be what all of our interested nursing homes are using. So it's a little bit of a hump to get over the very beginning of the project, but that is the biggest ask on our end is that survey and helping us get our external access set up. And then the rest of the record abstractions and chart reviews, our team completes ourselves.
What kind of infections are you focusing on?
So right now we are collecting information about any and all unplanned hospitalizations. I think trying to get just a broad overview of what sort of infections are going on in that sense, and then looking as well at if this patient does have a pathogen that comes up in a lab, what kind of susceptibility testing is being done, if any, on that pathogen, and then kind of looking from there at what antimicrobials are they being prescribed as well. So trying to follow that whole path through.
Well, thank you for raising our awareness about this and inviting us to participate. I hope that if anyone's interested, you do submit your questions to Catherine and to Dr. Czaja. If you need some help, just contact me and I'll put you in touch.
Okay, thank you. We really appreciate you letting us be here today.
Yeah, thank you all. And I guess I just wanted to announce for folks, because I know Lauren Beely, our antimicrobial stewardship pharmacist, has been on this call in the past, and she's moved on to another job. So if you have other antimicrobial stewardship questions, please reach out to me, and we're going to work on trying to find support. We do have a new antimicrobial stewardship epidemiologist, and in terms of finding some of that subject matter expertise, we're working on that as well. Thank you. Hope you all have a great rest of your time.
Yeah, thank you for sharing that. Right. Well, our next speaker is Dr. Michael Horne. He is a cardiology nurse practitioner and assistant professor at the University of Colorado College of Nursing. He's board certified in adult and geriatric populations and has an additional cardiovascular knowledge certification from the American College of Cardiology. He was inducted as an associate of the American College of Cardiology in 2025. He's here today to talk to us about lipoprotein, apoprotein, and new ACC dyslipidemia guidelines. Go ahead.
Great. Thank you. Thank you all for having me back. Can you hear me and see everything okay? Okay, great. So yeah, we're going to talk about a very quick overview of the new dyslipidemia guidelines. There's 300 something pages in them, and then lipoprotein A and ApoB, because those are newer things that you're not new. They've been around forever, obviously in the body, but that we're hearing about in terms of treatment, and they are featured prominently in the guidelines. So thank you for the warm introduction. I'll skip that slide. I appreciate it. So what we're going to look at is just a brief review of lipoprotein A, apolipoprotein B. Not going to insult your intelligence. I know you're familiar with these things, but kind of in terms of what were the new things about them. A very quick overview of the dyslipidemia guidelines. My normal dyslipidemia guideline overview for these is like 90 minutes, so we're going to condense it, right? But I've put some stuff in the appendices to help you as well. Specifically look at how they relate to older adults, because obviously that's our population of focus primarily, although there's certainly some younger people in long-term care also, and end with a summary of the key changes. So I'm going to go pretty quick. We'll hold questions to the end. But so lipoproteins obviously basically just carry cholesterol. They do more than that, but they carry cholesterol in the body. They have cholesterol in them. They have protein, apolipoprotein. And really their function is depending on kind of their size and their components. So we have VLDL that transports triglycerides. We have LDL proteins that transports LDL cholesterol. We have HDL that actually brings some cholesterol back. And we have this new thing, or new in terms of popularity, called lipoprotein a. So LP is basically like an LDL lipoprotein particle, except that it has an apolipoprotein A attached to the apolipoprotein B. So that's really the only difference. The reason we're all concerned about it now, looking at it, is that it's been shown to be extremely atherogenic and increase cardiovascular risk independently of any of the other things we've typically measured. So what are these apolipoproteins? This apolipoprotein A that's connected to the lipoprotein a, they're the protein component, right, of the lipoprotein molecule. And whether or not they're good or bad kind of depends on what they're attached to. So the bad ones, apolipoprotein Bs, which we'll talk about measuring again in a minute, LDL, VLDL, LP, the ones that are basically atherogenic. Apolipoprotein A1, that's connected to HDL, basically protective in general. And then, as I mentioned, apolipoprotein A, not A1, but A, who named these, who I don't know, right? But is connected to lipoprotein a, and it is definitely a high-risk measure. So what we've typically measured, and what is in the new guidelines to be continued, but with some augmentation, is LDL-C. LDL-C measures the total amount of cholesterol in the LDL particles, and that's a good measure. Apolipoprotein B actually measures, in effect, the total number of LDL particles, because there's one per LDL particle. Now, intuitively, you might say, well, isn't the total amount of cholesterol more important than the number of LDL particles? Actually not, from a cardiovascular risk standpoint. It's the number of particles. So since apolipoprotein B measures the true number of LDL particles, it's actually a better measure than LDL-C of cardiovascular risk. Now, the guidelines, as we'll talk about in a minute, have not changed to do with LDL-C at all, and I don't think they ever will. But they have added apolipoprotein B as an additional measure. And if you already are doing that or seeing that, that's the reason. So what about that lipoprotein A? That's the other kind of new one, right? And that is basically a special type of LDL, I'll call it, that has the lipoprotein A added to it. And it behaves similar to LDL in that it carries cholesterol, but unfortunately, it actually confers additional risk. This apolipoprotein A that's attached to it has things called Kringle structures. And basically, the interesting thing about those is that they somewhat in structure mimic plasminogen, which obviously helps break down clots, but they don't additionally help break down clots. They actually interfere with plasminogen since it's similar. So one additional risk factor with Lp(a) is that it can actually prevent the breakdown of clots. And if it's a clot in the coronary artery, that's not a good thing, right? So that's one additional risk that Lp(a) confers. Then just like LDL cholesterol, it carries cholesterol, right? Or LDL lipoprotein carries cholesterol. So all three of these basically contribute to making Lp(a) levels very indicative of higher levels of cardiovascular risk. The cutoff we use now, not necessarily the normal level, but for higher risk level, is 125 nanomoles per liter or 50 milligrams per deciliter. Nanomoles per liter is the better measure. That's what you'll see coming if you haven't already. So 125 is the number there, but 50 on the other. And the risk isn't just like when you hit that, it's there. If it continues, it's even higher, right? So it's a linear relationship. So if your Lp(a) level is 400 nanomoles per liter, that's significantly higher risk than 125 and certainly higher than if it were normal. What determines it? Well, the interesting thing about Lp(a) is it's not lifestyle determined. It's genetically determined, 90% of it, and it's determined by age 5. So there's not a lot we can do about it. There are some factors that may increase it over time, pregnancy, menopause, and renal disease, but not significantly. So diet and lifestyle, while they are certainly very important for overall cardiovascular risk, for sure, if you have elevated Lp(a), they're not going to reduce the Lp(a) number. We'll talk about what we can do about it in just a minute. So this is just a summary, a good kind of takeaway from it that talks about it being a non-genetic influence. The prevalence is estimated to be as high as 20% in the worldwide population, so it's not a number of people. And as you can see by that bottom line down there, the increased cardiovascular risk or your stenosis risk on the first one is very substantial and is even higher in some people. I have some patients who have 400, 500 level of Lp(a), and that's a very substantial risk, even if they have no other risk factors. So let's look at the guidelines now. Now I'll kind of give you the background there because these are included in the guidelines. We're going to look at the overall guidelines. They just came out in March. And I'm going to focus primarily, of course, on older populations in general for this meeting, but just to give you a general feel. And this is truly a very high-level summary because the guidelines, one of the things they did is they went very individualized in terms of treatment paths. So it's very hard to summarize them on one page like we could for the old guidelines, or you can for the hypertension guidelines. But in general, the message is screen earlier, treat longer. And so we're going to screen starting at age 9 to 11, unless there's familial hyperlipidemia in the family or other risks, then actually at age 2. Again, at age 19, every 5 years after that, unless we're treating them, we might screen obviously sooner. LDL goals are back. You know, in the last iteration of the guidelines, we just went from we want to reduce by 40%, 50%, whatever. Now we have goals again. So they're less than 100 milligrams per deciliter, less than 70, or less than 55, depending on the risk category, of course. And we'll talk about that in just a minute. And then for older people, you'll see it's basically treat longer. I'll talk about it, but for secondary prevention, the recommendation is treat forever. And for primary prevention, it is to start up to at least 79 based on the new risk calculator. And there's actually some guidelines about starting even after that for people that have at least 2.5 years of life expectancy. The other new thing, and this was included in the 2025 hypertension guidelines, so it's not brand new to most of you probably, but is the move from the pooled cohort equation to the prevent ASCVD equation. And And that's going to be kind of the new way going forward, at least with the cardiology risk estimates. One thing to be aware of there when you start looking at the buckets that this puts people into, the prevent ASCVD estimates things lower. So as an example, borderline in the pool cohort was 5.7% risk of a 10-year ASCVD event. Under the prevent ASCVD, it's 3 to 5%. So when you start seeing the detailed guidelines and start seeing that we're going to recommend statins as early as 3 to 5% 10-year ASCVD risk, it's because that's basically equivalent to the old 5 to 7 in the pool cohort equation. It's basically the same amount they've estimated. It's about the same number of people. The other thing to be aware of in that prevent ASCVD equation is it starts at age 30 and goes to age 79. So that is an expansion of the age included on both ends. So those risk markers we talked about, what are we doing with that Lp(a) and what are we going to do with that apolipoprotein B? So matching what was already in the national lipid guidelines, what was already in the European guidelines, now the ACC has added the recommendation that we measure Lp(a) once, at least once, in all adults. And for those with familial hyperlipidemia, we may do some cascade testing of relatives as well. So the reason for measuring this at this point, and we'll talk a little about treatment at the end, but we don't have a medicine to reduce Lp(a) yet. We may, by the end of this year, have an FDA-approved medicine, certainly early next year. And some of those medicines reduce it dramatically, 80 or 90%. But at this point, we don't. So the value of measuring it now is it's an added risk factor. So when you're looking at somebody that may be in that borderline starting on a statin or not, at whatever age they're at, and you're trying to help them decide should they not, just like coronary artery calcium, Lp(a) is one of those additional risk factors that you would add in to say, okay, they also have this. Yeah, we should probably do something aggressive like starting the statin. FYI, statins don't reduce Lp(a). They actually increase it slightly, not a lot. But since it is a risk factor, starting a statin for someone that may be on the borderline and has elevated Lp(a) is a good idea because you're reducing their overall cardiovascular risk, even though you're not specifically targeting the Lp(a) number. And this is just a series that shows that it does certainly get bigger from a risk standpoint as that number goes up. And you may be amazed when you do an Lp(a) on some of your patients who are fine and don't have any particular apparent risk factors, and it's high. The other one is apolipoprotein B, and there's really two uses of that measure in the new guidelines. One of those is for people who are, we've measured their LDL-C, we decided they should be on some kind of lipid-lowering therapy or statin and or others, and we want to further refine those at higher risk to potentially also add an apolipoprotein B goal. So they may have an LDL-C goal of 70 and an apolipoprotein B goal of 70. When the apolipoprotein B and the LDL-C numbers are about the same, that's generally good. That doesn't mean you just have a bunch of particles. That's kind of normal. But when the apolipoprotein B number is way above the LDL-C number, that's when additional treatment could be necessary. So that's the purpose of adding that measure. The other reason is the same thing as the Lp(a), and that is it's simply an additional risk factor. So again, if you're on that borderline of does this person need a statin or not, if they have elevated apolipoprotein B as well, then that may push you to that reason, just like with coronary artery calcium, like we've been doing for a long time. If you're on that borderline and it's coronary artery calcium is above 0, it suggests leaning more toward adding some type of lipid-lowering therapy. From a management standpoint, like all guidelines in the last 3 to 5 years, they're certainly emphasizing lifestyle more, which is terrific. We should. I mean, there's no doubt about that, right? So you'll see more detail in there about that. And then the actual management approach in terms of like medications, again, is broken down much more granularly. The new hypertension guidelines from last year, they had just one chart, which was great. It showed everything, and then they talked about some exceptions, but it was easy to use. This is not. You'll see in the appendices a bunch of detailed flow charts based on whether or not somebody has existing atherosclerotic cardiovascular disease, severe hypercholesteremia with LDC above 190, diabetes, and then those are all sort of secondary-ish type preventions or primary prevention. And again, that being adults 30 to 79, whose we're going to do a prevent score on. So that's kind of the big buckets. I have one slide I'm going to show you that tries to summarize those, so you without having to go through all the detailed flows. But for actual treatment, you would want to go through those. But I'm going to somewhat summarize them. And then they also included some additional considerations that were not in older guidelines. They have a special path for adults with subclinical atherosclerosis, which is basically defined as someone, for example, who had a CT for looking for lung cancer. They were a smoker, and they incidentally found they had a coronary artery calcium score of 1,000. And then they're like, uh-oh. So there's a path for that kind of stuff. Hypertriglyceridemia, triglycerides, high triglycerides. That's always a hard one for me. In the past, we've well, darn, eat better. If it's over 500, we might consider a fibrate. Now there's actually a more detailed flow for things that you may want to do with those. And diet and lifestyle is a big piece of that. And avoiding alcohol totally is a big piece of that. And then, as I mentioned, the elevated LPA, which is, again, more as a risk marker at this point, but knowing that we're likely going to have several medication alternatives as soon as later this year to address that. And then there's some additional lifespan considerations, which we'll certainly talk about with age. So here's my one attempt to pull all that together on a chart, at least, and it gives you some level of idea of what's in there. And you start from left to right. So if somebody's got clinical ASCVD history, that's where you start. You don't worry about the other stuff, right? And you kind of go across. So if they have a history of atherosclerotic cardiovascular disease, you're going to put them on a max statin and other lipid-lowering therapies as needed. And they're going to have a goal of either less than 70 or less than 55, which is new, not for Europe, but for us, based on the characteristic of either they're high risk or not very high risk. And most people you'll find with clinical ASCVD actually are very high risk. And the second newer recommendation is lifelong treatment. Keep them on it. Now, if they got a month left to live and they're on hospice, not a big deal, right? But in general, keep them on it. They don't fall into that bucket, but LDL-C is above 190, they fall into this bucket, the severe hypercholesteremia. Again, a max tolerated statin or other medicines as needed to get goal. And now we're breaking the goal down basically into if they have this high cholesterol and other risk, it's less than 70. If they don't have other risk, it's less than 100. If they had ASCVD, they'd already been cut off by the first bucket anyway, and it's less than 55. Diabetes has its own flow as well. It starts also substantially earlier than the old guidelines. Now starting at age 20 to 39, if someone has diabetes and their prevent risk score is greater than 3%, they're suggesting start at a moderate statin. So on a 21-year-old with diabetes, potentially. And then the second groupings are similar to the old guidelines, which is age 40 to 75, based on their prevent score, you either would start a moderate statin or a high-intensity statin, and their goal would either be less than 100 or less than 70. For people above age 75, they're suggesting a moderate statin. And we'll talk a little more about older folks in just a minute. And then finally, if none of those hit, right, you're in primary prevention, and we're looking at a moderate or maximum statin basically to hit the goal. And the goals are, in terms of considering starting a statin, would be, whoops, let me go backwards, would be if they're in that borderline level of 3 to 5% 10-year ASCVD risk based on the prevent calculator, and they have some other risk enhancer. You might want to start it with a goal of LDL of 100. If they're 5 to 10%, even if they don't have any other risk enhancers, the recommendation is to start a statin. And if they're above 10%, start it, but with a goal of less than 70. So as you can see across this, the general message is we've expanded on both ends, start earlier, go longer, have a little more aggressive goals. Let's look at our older population. So from a latest data standpoint, there's been more analysis of both some new and some old trials. And from a secondary prevention standpoint, so someone has a history of ASCVD, they've had a heart attack, they've had a stroke, they've had whatever. Again, the recommendation based on benefit versus what appeared to be fairly low risk is to continue that lipid-lowering therapy medication lifelong. So that's a pretty hard recommendation. From a primary standpoint, the new guideline prevent calculator goes up to 79 versus 75. So that's obviously one increase. And then there's some other statements they made I'll show you on the next page. And this is based around some additional studies on primary prevention, starting primary prevention in someone that's over 75. There are 2 trials ongoing right now, STAR-E and Preventable. They'll come out probably later this year. They're going to show us even more stuff. There's people 80 years old plus in that. The challenge on a lot of these, all of these, is there's not a lot of long-term care residents included. So we're still going to be a little bit on, our own there, but the ACC has made some statements, at least on the next page I'll show you about. But that still represents still is an underrepresented group in the trials. And then specifically on deprescribing, which obviously we all should appropriately look at times, there's really only a little trial that they looked at, and it actually didn't show any benefit from a side effect standpoint or improving quality of life of significance, but it did show some harm. So there's certainly some, and this is for primary prevention primarily, there's certainly some consideration around deprescribing to whether you want to do it or not. So here's specifically what the recommendations are for older adults in the new guidelines. First of all, as we all very well know, especially with long-term care patients, that's a very heterogeneous group. You need to make a decision on a patient-by-patient basis. There's no big bucket because a 70-year-old can act like a 70-year-old, or they can act like a 90-year-old, or they can act like a 50-year-old, right? In terms of physiologic age. So everybody's very different there. But in general, they've made the statements that for adults greater than 75 years with an estimated life expectancy of at least 2.5 years, it may be reasonable, and this is for primary prevention, it may be reasonable to initiate a moderate intensity statin for primary prevention. For secondary, again, we're going to keep them on it. If they have less than a year to live, it may be reasonable to discontinue that for primary prevention. If it was secondary, again, keep them on it. So that's really the two sort of statements they've kind of come out with from all the data. And then just like any age, if you're undecided about any of this, potentially a coronary artery calcium score might help you make that decision. And I would say LPA level and ApoB levels as well. This just summarizes that up. Again, prevention through age 79 at least, with the consideration beyond that if they've got 2.5 years to live, and intensive lipid-lowering therapy for secondary ASCD prevention for all ages, and obviously looking at it on a per-patient basis. Quick review of the drugs, more for reference. I love this chart, though, because it kind of does show what works where. Zetia obviously blocks cholesterol absorption from the gut, sorry. PCSK9s and inclisiran, which is a sort of PCSK9 medicine, help uptake LDL, and bempedoic acid and statins help reduce the production of cholesterol in the liver. My comment on statins, right? Don't believe everything crap on the internet. That's true for everything, right? Not just statins, but there's a lot of stuff out there, right? I loved it one time the patient told me, and this was a patient who'd had 2 heart attacks, that their life coach told them they didn't need their statin anymore. It was interesting. In any event, the true things that statins absolutely can do. Number one, in rare cases, they can cause rhabdomyolysis or liver dysfunction. Doesn't happen a lot, but be aware they can. They will or can increase A1C maybe 0.2, 0.1, so like from 7.1 to 7.2, 7.3, whatever, or even somebody with prediabetes might even push them into diabetes from an A1C level standpoint. However, the benefit from someone who's a pre-diabetic or diabetic getting a statin is far greater than that small little increase. No issue with cataracts. In terms of dementia, they actually have been shown to probably help it versus hurt it, because there were some rumors about that at one particular point. And although you don't have a lot of pregnant patients, obviously, in long-term care, do recognize there is a change there, just an FYI. So they always were pregnancy category X. Now there is consideration based on additional data that they've looked at, that if someone is at really high risk of cardiovascular disease, we still might want to keep them on a statin even once they're pregnant. Not start one, but keep them on one. Obviously, a very per-person decision. The biggest thing with statins, as we all know, is muscle pain. And that affects about, on average, 10% of our patients, although there's a wide range. Interesting enough, there's some really good studies that isolated all the confounding factors and said that the actual true effect from the pharmacological effect of the statin is only about 1 to 2%. It's not 10%, it's about 1 to 2%. But the problem is, even though that's true and this muscle pain can be caused from something else, if the patient feels it's caused from the statin, they may not take it. And that's the problem, right? Is that discontinuation in patients that need it, especially for secondary prevention, greatly increases their cardiovascular risk, increases at 30 to 40% on average. So we want to do something to fix it. We can look at dose reductions. We can look at alternative days. We can definitely look at alternative statins. Rosuvastatin, for example, is less lipophilic than atorvastatin, typically has less side effects. And now the great news is, and I'm going to hit very quickly a few of these, we have a lot more lipid-lowering alternatives to statins than we used to. They are still mostly not generic, unfortunately, so they're expensive, but at least we have the alternatives for people that can't tolerate a statin or need additional medicines beyond the statin to hit their LDL targets. Zetia being one of those that's been out the longest, reduces LDL levels, not as much as a statin, but it has very low side effects other than a little bit of GI intolerance, typically no muscle issues. PCSK9 inhibitors, extremely strong medicines in terms of LDL reduction. They're sub-Q injections, so that may bother some people, but there are some oral medicines in the pipeline right now. Typically, very few side effects. And bempedoic acid, which is kind of one of the newest ones on the block, along with inclisiran, which is also a great statin alternative or added to statins, which reduce LDL cholesterol a reasonable amount and also reduce coronary events. And again, very few side effects. It is also an oral medication, but do be aware if you have a patient that's gout, that may be a consideration. So let me summarize my take-home points here. The gist of the guidelines is treat dyslipidemia earlier and longer, and especially earlier. That's really the focus, because we know, like smoking pack years, lipidemia years, right, where you've got higher cholesterol longer is more damaging. So if we can stop it at age 25, we're a lot better than if we stopped it at age 45. Individualized treatment, of course, based on the patient, more so than in the past even, and move to the prevent calculator from the pooled cohort calculator. The goals are back, again, 100, 70, 55, depending on the risk factor. And then apolipoprotein B, LP(a), and coronary calcium all can be used as additional measures if you are unsure of where should somebody be starting a lipid-lowering therapy or not. And from an LP(a) standpoint, we should measure it regardless, because we are going to have ways to treat it in the future. The reduction down to 55 for secondary prevention for people at very high risk, that was not in the old guidelines. It already was in the European guidelines, but it's officially in the ACC now. And again, from an older standpoint, age standpoint, the recommendation for no age-specific limitation for secondary treatment to keep that going. And then the increase from 75 to 79 on the prevent calculator, and the general statement that if somebody's got at least 2.5 years left to live, based on best guessing, that there could be some benefit of considering a statin. The appendices are just for your handouts or use. There's a small patient case to show you how to go through this, and then I've actually included all the detailed flows. And so when you see these, you see what I'm talking about in terms of there's a lot more detail. I tried to summarize it up, but it is a lot more granular than it used to be. All right. Yes, I have something in question here, I think, or something. Let me see. Oh, thank you. I'll stop sharing. Any questions I can answer, across the board sort of questions.
I know, I appreciate you taking the time to boil down a very, very big topic to a short amount of time.
Sure, absolutely. And I put my email on there. Happy to always have discussions. I'm a true cardio nerd, so I always like talking about this stuff.
For me, it's been a while since I've thought about LDL targets at all. So I almost forgot. But once you've started or perhaps changed a dose of a statin, how long do you wait before you check the lipid panel again?
Typically about 3 months. You could do it between 4 to 12 weeks, but I typically do about 3 months.
What other questions do people have? You know, given the high, all those different pathways to it, perhaps if people have specific areas that we want to dig in deeper into, we could bring that specific part back to a future meeting.
Sure, absolutely. And they're good for reference. And like any of them, you use them a few times, you figure out. I mean, the differences and some of the nuances of them are obviously the levels themselves, but also when you would start a statin, how aggressive the goal is. Do you need to add an apolipoprotein B measurement to also go along with the LDL, which you would do at higher risk people? And which additional medicine do you use in what order? Typically after a statin, it's Zetia, bempedoic acid, PCSK9 inhibitor, and then lower down the list inclisiran. But again, all of those other than Zetia are unfortunately still new, so they are expensive. Let's see. I'm sorry, there was a comment here. I'm going to look at there. How can we put this into the workflow again? Yeah, that would be interesting. I'm looking at there's a question for all too. This is a great use of AI, right? Whether it's built into EHR tools or handheld to kind of go through these alternatives, right? So you're not going to memorize all the details, but treating dementia patients with previous data stated mental. Yeah, so the actual newer data. Now, again, there are 2 trials that should come out later this year on people above 80 with primary prevention. So we're going to have some additional data, and there are some people with dementia in there. But there was specifically, and I didn't include it in here, one trial that did look at people that included people with dementia, and it actually did show benefit and didn't show harm. So it didn't show additional risk factors necessarily. I mean, you're not going to have falls like hypertension or whatever, but there is more of a thought that there could be potential benefit. And I think, again, it depends on the patient. You know, if you've got somebody with severe dementia and they're got a 6-month lifespan, that's one thing, right? But somebody that may have a longer lifespan and they're happy and they're going to live another 5 years, we don't want them to have a heart attack, right? So you could certainly make the case potentially for that. How can we, let's see, there's couple questions here I'm going to look at. For statin-induced hepatitis conjugate. So if there is prior statin-induced hepatitis, in general, unlike muscle soreness, in general, so if the liver function enzymes are more than 3 times the limit or something like that, I would go with a PCSK9 or other medicine versus another statin in that case. When you're looking at the muscle symptoms, another statin for sure can make a difference. But when you're looking at the liver impact, a statin is kind of a statin from that standpoint. But a PCSK9 inhibitor, absolutely. I've actually had people that have very significant liver disease, and it's a little borderline on that as far as you use it or not. But I have, because they've also had very, very significant atherosclerotic vascular disease, and it has worked fine. So fortunately, there are a lot more alternatives now. How much these guidelines were based on? Most of these guidelines, almost all of them, were based on trials versus expert opinion. The nice thing now about a lot of the cardiovascular guidelines is there's so many people that have cardiovascular issues, right? That there are a lot of trials, there's a lot of data. Drug companies are very willing to do trials because there's such a population market, right? So we do have a lot of data. So most of the stuff in the ACC guidelines, whether it's this or hypertension or other, are actually evidence-based versus expert opinion. Now, when you look in the guidelines, you will see that there are different levels, of course, right? There's a level 1 and there's a level 2A and 2B. And so depending on the particular recommendation, the evidence might have been stronger. Yeah, great question. Yeah, they did have numbers to treat to prevent one event in some of the data. Yeah, they did. And that's how they came up with the 3 to 5% for the prevent calculator. I didn't include that slide, but in the ACC deck, there's a slide that actually shows number needed to treat and the break-even point, or the point they're using for 3% being the sort of 3 to 5% being the number versus the old 5 to 7. And that was based on number needed to treat. Yeah, good question. There's like a 300-page deck with the ACC. You can get on the ACC guidelines page that you can go through, right? Usually, well, the PCSK9 approval through prior auth is always a good question because, of course, it depends, somewhat on the insurance. But what I've found is typically, if certainly, and this may support it, actually, this will help. If they're not at one of the new goals on a max tolerated statin, you now have a goal versus just a generic reduce it by 40 or 50%, right? So I think it will help be able to improve, okay, they're on 40 milligrams of rosuvastatin. I can't go any higher. Based on the guidelines, their goal is 70, and they're at 95. Or in the more severe case with ASCV, right, maybe the 55. I would use that to try to get prior authorization approval for a PCSK9 inhibitor. I was fortunate. I do most of my stuff in Kaiser, and once we kind of agreed on something, we didn't have to worry about that as much, so it made life very easy. But I understand, obviously, that's not everybody.
Great questions.
Yeah, great questions. Thank you. Let me see, did I get all of them? I want to make sure that I did. I think I did, but okay. Yeah, we got that one. Okay.
I appreciate you taking the time to go through those questions and
Sure.
very
No, it's-
thorough responses. Yeah.
Again, thanks for having me back. I appreciate everybody's attention.
I did forget to put into your biography, Michael sees patients for Optum from time to time. And so we appreciate you bringing that post-acute long-term care perspective to us. All right, well, please direct any further questions to Michael. And now we will have Chad and Jenny give their announcements. Jenny, I see you on video. Would you like to go first?
Sure, absolutely. I'm going to go ahead and share my screen. Can you see it?
Can see it, yes.
Okay. I have a few short slides, but they are very full of information, so hang with me for just a moment. First off, I want to bring you up to speed on where we are now that we're halfway through our year. As far as a fiscal year goes, we're a little bit more than halfway. So we go from October 1 to October 1 of the next year. Basically, it's an early start to a year for the fiscal year with the regulatory tracking. So we do have a little bit of a shift in the front runners for our immediate jeopardy citations. We frequently do see accident, hazards, and supervision in that top level, but medication errors has risen up, and I wanted to touch on that with a little bit more detail for you. Remember that immediate jeopardy citations are situations in which they believe that there is a significant potential for immediate harm to a resident based on the present circumstance or something that already occurred. So here's what we're seeing. The 4 immediate jeopardies on medication errors, I feel this directly impacts you all because you'll notice these often are transcription errors, or they are nurse cooperation with the physician, reporting accurate information to the physician, etc. So I've actually linked also an article below about understanding the responsibilities of nurses in long-term care, because I do think that getting a full understanding of that for you all helps you relate to them much better. So the first of the 4 was seizure medications not given consistently. The individual did end up deceased due to mismanagement of seizure activity and a hospitalization. Essentially, there was a combination of holding medications for dialysis and then not communicating that information back to the treating physicians. A missed insulin dose resulted in a nurse following very poor clinical judgment and practice and not monitoring the resident when they administered more insulin to compensate. An INR simply not documented resulted in an order for a wrong warfarin dose because the INR they reported to a physician was from a previous INR and not accurate anymore. And then the last was just plain old transcription error upon admission, but it ended up snowballing on this facility. So an HIV medication cocktail was transcribed with only 1 of the 3 medications. The individual's viral load increased substantially, causing them potential for drug resistance to some of the components. So all of this directly relates to your oversight as medical director, and I wanted you to be aware of what we're seeing for trends. Also, just to keep you informed more than anything, I know you don't relate directly with the buildings on abuse deficiencies, but it certainly impacts your impression of your building and also their public face. And so be aware that we have an inordinately high level of abuse citations in Colorado. We are at an 8% of our total citations being for F600, which is the abuse tag, as opposed to a 2% national average. It's the only deficiency, this is why it gets cited this way, that is issued for an incidence as compared to non-compliance. So essentially the non-compliance is deemed because of the violation of the resident's right to be free from the incident having occurred in the first place. As you are probably keenly aware from your visits to our communities, you know that if a resident-to-resident interaction happens, oftentimes that is not something we have direct control over preventing. And then lastly, this is more of an FYI for you with regard to the financial viability of your buildings. This again connects also to your oversight of QAPI. These are the areas of quality measurement that directly impact Medicare reimbursement. In some of these categories, if the facility fails to report full and accurate documentation by the deadlines, they can reduce their Medicare reimbursement for the entire forthcoming year by 2% for all of their Medicare patients, which is our bread and butter. And you'll also note that many of these things directly impact your quality push in your building as medical director, trying to improve, for example, reduction in rehospitalizations or improvement of your SNF stays to actually equip people for successful discharge to community with increased ADL function, et cetera. So that's what I have for you today. Thank you.
Appreciate that. Thank you very much. That one slide that you had about the IJs, it was linked to an article about responsibility of a long-term care nurse. Is that an article? I thought that was an interesting title. Is that generally available?
Yes, it is generally available. It was a publicly available article through a journal. That was a request also from some of the providers at the conference that I attended for you all, that they wanted to better understand what nurses are actually responsible for and perhaps what their challenges are for maintaining a level of professionalism and high clinical standards based on being pulled this way and that. So it's a great explanation of what they're expected to do. I'll send that on to you, Singh.
I love it. Next, we have Chad Fear from the CDPHE. Hi, Chad.
Hi, good afternoon. So Joe and I had the opportunity to meet with CHCA at their spring conference, and we had some really good conversations about about a number of things. And I really just wanted to bring a couple of them here to share with you all as well. We've identified the need to increase our efforts. And as Jenny's slides would indicate, we do have a high citation rate for abuse. We do need to get a more consistent understanding, I think, between facilities and amongst our surveyors about the definition of abuse. Since the rewrite of the CMS State Operations Manual, Chapter 5, which talks about complaints and includes the federal requirement to report certain incidents, there's been an ever-increasing number of facility-reported incidents, exponentially, actually. There's just a lot of them. You know, we've recognized, though, that a number of the incidents that are being reported as abuse did not really meet the definition, the federal definition that's included in the SOM. So we're getting some stuff reported that's not abuse, or sometimes we're not able to determine whether that incident meets the definition or not. And so then it gets triaged. And oftentimes when we're talking abuse, it gets triaged at a non-IJ high level, which means if the incident did occur, it most likely has resulted in harm. Okay, so then we get in the whole definition about what is harm when it comes to as related to abuse. And I just think we have some a wide range of interpretations as to what that means. Again, with facilities and amongst our own ranks, amongst our surveyors. So we're working on tightening that up, and we'll be looking for some opportunities to have more conversations. You know, we did a traveling road show. I want to say it was last summer, but it's been a little bit longer than that. Time has flown for sure. But what happens is we don't have enough information. We end up going on site, and we're looking at things. Sometimes we won't recognize that it doesn't meet the definition of abuse, or should not have been in a facility reported incident until we're already on site. The risk that we run there is if we are not clear ourselves about the definition, sometimes that leads to citations. And we do have a good quality assurance process where maybe the surveyor is exiting and says, you know, the preliminary results have resulted in, will result in a citation for abuse. And primarily we're talking about resident to resident physical and verbal abuse. We see things, sometimes people just get in arguments and it gets reported as verbal abuse. And And I think then the example was, yeah, they had a spat and then they went and ate lunch together. Well, that's not really going to meet that piece. And we really have to, I think, more fully understand the psychosocial severity outcome guide so that we can determine was there an emotional or mental response to the engagement and how significantly did it affect the person. In order to more effectively triage these reports, it's important, again, for us to have sufficient information to understand the incident, the resident's response to the incident, and the facility's response. Well, what did you do? Because if we can determine that there wasn't harm and the facility took reasonable steps, reasonable measures to correct the issue, protect the people, we won't necessarily have to triage it in a way where we have to come out and conduct an investigation. We need to get more information in the initial report and in the final report so that we can help make those determinations. So this is something we really want to work on system-wide. Again, I pointed out it's been some time since we've had a collective conversation about that. And we've had turnover in surveyors, we've had turnover in staff who were able to attend our discussions. So some folks who are in leadership positions now were never got to have that conversation. So we're going to be working on some of those things. Kind of along those lines somewhat, I also wanted to point out that we've received a number of reconsideration requests from a few corporations. So after the survey exit, we've received some emails saying, hey, you know what, we feel like there's something else for you to consider. Or maybe we don't feel like the surveyors saw this and saw our response, and the response may be able to allow us to see something as past noncompliance as opposed to current deficient practice. Because we have a few facilities doing that, we want to open this up to everybody. Okay, and I'll kind of go through what this is really looking like. So standard to the survey exit, the surveyor informs the facility that they have an opportunity to provide additional information by the close of the next business day. We've been doing that for years. So this piece is a bit new. So what we're asking is that if you really feel like, no, there's more to consider here, and we're asking folks to please be judicious in their requests because we don't have the bandwidth to review an entire, we have a QA process. We look at and we review everything prior to it being sent back out in a 2567 or the deficiency report. That is already happening. This is in addition to, and these requests are coming to Joe and to myself. So what I would like to ask is if you make a request, send it to the surveyor who was investigating this, the team coordinator. We're also going to be providing, we've created a survey oversight supervisor. It's not a new position, it's a new responsibility. We rotate through this. And what it is off-site support for that survey team to discuss, to talk through any findings that they have and make sure that, if we decide that something will lead to a citation, that we're being as accurate as possible. So that information, the business card for that person will be handed to the administrator at every survey, as well as my business card. And then to also CC Joe and I on that in that request. We'll get together at our office, look at the surveyor's findings, look at the information the facility wants us to consider. Sometimes it doesn't change anything. Sometimes tags get moved because maybe it belongs somewhere else more appropriately. And other times we say, you know what, you've answered the question and this is not going to be a citation. So again, please be judicious about it. We would like the opportunity to eat dinner and rest at night because I could just see that, as passionate as everybody is, we might just get a ton of stuff. But yeah, we do want to make sure this is available to folks for the purpose. And it is our intention to be as accurate as possible, whatever that might mean. So I did want to share that with you all. That's what I have for you today. And if there are any questions, you can ask them now or send me an email and I can discuss it at length.
Thank you, Chad, and thanks for allowing room for that conversation. I know things don't always fit the check boxes and those definitions aren't always just black and white, so appreciate your acknowledgement.
You bet.
Well, that does bring us to the conclusion of our meeting. Our final announcements were just going to be that we have journal clubs coming up on Thursday, 12:30 to 1 p.m. Ian Cordes is our PaltMed Colorado Director of Operations. If you haven't met him, if you didn't say hello to him at the annual conference, take a moment to say hi to him on Zoom, one of our Zoom meetings, or send him an email. He is always available to all of us for support. And sometime in the next month, we will be sending out ballots to all of our current members to elect our PaltMed Colorado board officers. And you can see on your screen the list of candidates for all of the the current positions. So watch for that in your email box. Thank you and have a great day. Thanks for joining us.
Can I?
Yes, hi.
Chad, I just have one quick question, okay, just to wrap up what you said. If there were like 3 key points that if we were to tell our facilities that they needed to include in their request if they wanted to review or re-review, ask for, their survey, what is it that they need to include in their reconsideration? What is it that they need to submit for the strongest reconsideration, since you may not have openings for every case to be reconsidered?
I think you jumped off. Unfortunately, it's a great question.
Do you have, Dr. Reddy, do you have his email address? Do you want to just kind of ask him? And if it's a general, all of us, maybe.
Is it in our monthly meeting things? Is his email address in there? If not, then I will take that.
Yeah. Why don't I send you an email?
Okay.
Learn
Sounds
together.
great.
Might be a good protocol for all of us.
Okay, great. Thank you so much. Thank you all.
Yeah, have a great day.
Have a great
Bye.